Dr. Varsha Rathi with me. I would like to confirm if we have Dr. Gopal Raju, Prabhakar Shastri, Parvez, Sabyasachi. Anybody available? Okay. And Praveen Kumar, you're here. Pankaj, Patnayak, Prasant, Pooja, you're here, good. Anita Mishra, and I'm here. So I actually have to go to the airport, so may I give my lecture first, and then I'll request Dr. Varsha to take over on that. So I'm going to talk. So आप please मेरे slides पहले लगा देना. I'm going to cover the concept of standard treatment workflows in ophthalmology. This has been initiated by the ICMR, WHO, and the National Health Authority. Why do we need standard treatment workflows? Basically, in health systems and public health, there's new scientific evidence and rising healthcare costs. So healthcare providers are not able to keep pace, particularly within the public health system. And there are also bulky, voluminous treatment guidelines. Of course, these are guidelines. They have to be taken in that spirit because when you're handling a patient, there's a lot of individuality in what the physician and the patient situation demands. So they are guidelines and they're not hard and fast rules. Of course, there's a very high doctor-patient ratio, and there's also a lot of pressure on being up with the current protocols. Physicians require a simplified, updated approach and a guideline, and also now there are a lot of non-physicians who are also engaged in the healthcare management systems, as I will explain later on. So it's not that they're going to provide the treatment, but they have kind of a checklist by which they can reconfirm with the physician or the organization about any queries. So standard treatment workflows was a kind of a one-pager concise document which was designed to be utilized at various systems within the healthcare delivery system in our country from primary to tertiary care level, and they've been made available by Government of India to be adopted and followed by all providers. So the goal was to empower primary, secondary and tertiary care physicians and surgeons towards the overall goal of universal health coverage with disease management protocols, and the objective was to formulate generally universally accepted clinical decision-making workflows based on best evidence available. And there was also a side benefit that with the rolling out of the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, that is the sort of a government health insurance system, there was a requirement that there are certain sort of levels which could be considered for considering what should be the treatment that should be authorized or provided. And allowed for, accounted for. Of course, there are many states who have their own individual insurance systems, and there are individual insurance packages, and it's not necessary that they all be equal, because in different parts of the country and different requirements, there would be different expenses. So what was the process followed? Initially, it was decided that this was across disciplines, and within each discipline, there was a discussion as to what were the doable disorders and which could be done within a particular time frame. Then there was a group of experts who were put together from different black backgrounds, and a review of available current best practices. Looking out of that, what were the evidence available and how could that be modified depending upon the local scenario. Then discussion and pre-finalization of the content, which was then conceptualized and went through different iterations of the model, because it had to be simple, it had to be as clear as possible, and it all had to be concisely put onto one page. and then it was made available after the printing and dissemination. So generally the experts were from the All India Institute of Medical Sciences, PGI, MER, Chandigarh, government medical colleges. It also included state and district level program officers, the WHO, private healthcare providers who are also important stakeholders, members of professional associations, super specialty private hospitals, and primary healthcare physicians, trying to make sure that you included the whole gamut of healthcare delivery models available in the country. And then there was a structure, the structural framework was an advisory committee, and then there was under that an STW team, and then specialty wise subcommittees, and then an editorial board, and then it turned out into a form of a book, a mobile app, and a web portal. Now, coming to ophthalmology, initially there was ophthalmology is a huge subject, very vast into itself, and taking into view the data about the important causes of blindness in our country, and also the largest requirement for healthcare service delivery according to what were the requests coming from across the country, we decided on 3 disorders: cataract, glaucoma, and diabetic retinopathy. So for cataract, there was a simplified thing of symptoms, signs, what should be the generalized expected systemic assessment as a baseline, then an ophthalmic examination, again primary, secondary, and tertiary level, preliminary examination, then the essential examination, and desirable. Now please remember, this is at different levels. It's not that in at a so like a basic level, and then you will refer the patient to the higher level. So this was how it was divided, and largely this was at the primary healthcare level, that it will be the initial screening, idea being that any patient with these criteria would then be referred to the higher level for the for treatment. So there were the essential. Then once you go to the higher level and cataract is confirmed to be present, which is requiring surgery, there were certain essential investigations, certain desirable investigations. Here, for example, there could be a clinical assessment of a blocked nasolacrimal duct, and then there were optional investigations. Then the indications for surgery, and then proceed for surgery as indicated. And if cataract was found to be absent, the idea was to look for other causes for impaired vision and refer as necessary. And then the cataract with comorbidities and with systemic comorbidities, it was again subdivided as to what were the important associated disorders, and that they would be taken care with the help of the associated medical specialist. And then there was also a protocol for management and follow-up, fitness for surgery, and the quality assessment parameters also, so that there could be a monitoring whether the general level of healthcare delivery at various levels is acceptable according to the norms, and post-op care. So this is all in one page. Here I split it up into 3 for the convenience, but otherwise all in one page, and you can just go down the list and apply. Coming to diabetic retinopathy, then again there were key points. What should be the preliminary screening, what should be taken in the history, what should be done in the examination, and then they were given standard charts as a kind of sort of a checklist to compare. I'll just take another minute. And then there was a classification, and then again indications for urgent referral. And then again guidelines for management. I'll just take a minute. And then we have glaucoma. Glaucoma was a third disorder. Again, certain key points were identified, then the history, the signs and examination, and what should be done in the OPD, what should be considered as the indications for referral, and the suggested management protocol based on the intraocular pressure, and then what is the management at every level, primary, district, as well as the tertiary, and then the red flags were put for urgent referral. So this is how we have these 3 disorders. So they're available, as I said, in a book form and an app form, as well as on at the website. And this is the mobile app that could be used, which could be downloaded. Then it was released. This was a central release, and I'd like to acknowledge Dr. Ashu Grover from the ICMR, who has played a key role in coordinating all these activities and making sure that they came out to be at a suitable level. And for future, one could have a discussion as to what additional panel, we were very keen to include corneal ulcers and trauma, as well as pediatric eye diseases, and that perhaps when they come up with volume 4, one could add these disorders as well. But at the moment, it was going by the large burden of disease and depending upon the healthcare delivery pattern that we have. With that, I'll stop here. I'm happy to take any questions. Yeah. Okay.
Thank.
No longer. No longer. No. Clinically, you can easily rule out an infected lacrimal sac, so it's not essential. By pressure on the sac, absolutely. Yeah.
Okay. Oh, I was about to ask, that was one. Second, you have mentioned that B scan is advisable for total cataract patients. So
Yes.
it's not must.
You know, it depends upon the situation where you are, because B scan is, if it's a total cataract, depending upon how much in the periphery you are, that is why it was written in a district hospital, for example, with guarded prognosis, you can go ahead. So that is how it is, keeping that in view.
Okay, thank you.
Yeah.
Any other questions? Thank you, ma'am.
Okay. Thank you. Thank you so much. Yes, sir. Yes. No, see, it depends upon where you are. See, this is the healthcare delivery system. So obviously, if you are in a setup where it's available, there will definitely be a legal implication. But this is a guideline right in the periphery, so that people over there don't, have to suddenly start purchasing a B scan if it's not available. Definitely, if it's that is why it's a guideline and a workflow. And basically, if you have a total cataract, you would like to do a B scan to know what is behind, to plan accordingly. But if it's in the periphery, then you would, it may not be possible. Then you have to do guarded prognosis depending upon the situation. So that is the difference between this kind of a universal guideline which is provided very, very remote areas. Sometimes it is just not possible. And it may be going in for phacomorphic. You leave that patient there, he may go into phacomorphic glaucoma or some other complication. So in those situations, explaining the status, it can be done. You have sometimes very elderly people who are very far off, then you may have to do it with guarded prognosis. But certainly, if you are in a setup where you're in a metro, definitely you would have to do a B scan, and you would like to, and it's not an issue for you because you have it. The situation is when you don't have it. Yes. So, yes. Yes, you can. You can, because this is a help for you, and you can check the digital pressure. If the pressure is low, you may suspect a retinal detachment, and you may have a vitreous hemorrhage. So with the explained consent that there's a total cataract, you can look at the pupillary reactions, and you can say that these are the things we cannot rule out. We'll go ahead for the surgery. If anything comes after that, we'll refer. And if it's absolutely fine, then patient is happy and you're happy.
So it's like doing just a good documentation of what you are doing and what you have explained to the patient. Consent form.
Yes, yes, definitely. Yes, absolutely. You should have a written consent that in view of the extensive cataract, that's difficult to predict. So, so therefore, it is guarded prognosis, under guarded visual prognosis.
Thank you.
Thank you. And you can also explain that if anything happens, it's not necessarily due to the surgery, it could have been pre-existing. That's very important to explain. Yeah? Thank you. So thank you for your interest, and now we will have the lecture by Dr. Praveen Kumar Dhuvatpare. It is preventable blindness amongst persons with certified visual impairment in tribal districts of central India.
Hello, good morning all of you. I am thankful to Scientific Society AIOS for this opportunity. I have no conflict of interest to disclose. This is outline of my presentation. As we all know, visual impairment is a significant health problem with a large burden on person, family, society, and economical burden to country as well. And this visual impairment can range from mild to severe. So to cover that range, Government of India in 2018 had given a gadget notification in which it had categorized into two subcategories, two groups: low vision and visual impairment and blindness. Low vision is something with best corrected visual acuity between 6/18 to 3/60 and visual fields less than 40 degrees, central 40 degrees to up to 10 degrees. And blindness can either be total absent of sight, or it can be best corrected visual acuity less than 3/60 and visual field less than central 10 degrees. The majority of causes in literature covers all the causes which can be easily treatable like cataract, uncorrected refractive error, or it can be non-treatable like macular diseases, and few of them can be avoidable like glaucoma, diabetic retinopathy, corneal disorders, and ARMD. However, majority of literature primarily focus on the treatable causes, and very few studies have been done to focus on the causes of permanent visual impairment, so we needed to analyze those causes. So, in our tertiary care institute at Government Medical College Gondia, we conducted a study in which we studied the clinical profile of person with visual impairment, and we focused on the causes of preventable causes of blindness. Ours was a retrospective study conducted at our institute. We studied the case records of last 1 year. We had included the case records of both low vision as well as blindness candidates. Person who had applied but were not entitled as per government regulations were not included. And we found among our sample size of 815 candidates that majority of them were between the age group of 11 to 50, and there was a huge male to female disparity with 2:1 ratio. Among the common categorization, the one-eyed patient with 30% visual impairment were almost 41%, and 18% each were from the 40% visual impairment and 100% visual impairment. The exact clinical data was not, clinical categorization was not possible, so we divided into following groups, and we can see the majority of them, means almost 61% of them had a congenital cause, 17% was there for traumatic causes, and other non-traumatic acquired causes were there in almost 12 to 13%. In male, the traumatic causes were more commoner than females. In congenital causes, the commonly encountered diseases were congenital diseases like anophthalmos, microphthalmos with colobomas, hereditary maculopathies, nystagmus, congenital treated cases of congenital cataract and glaucoma, but despite of treatment, the amblyopia was there. High degree of refractive error in early childhood. In traumatic, we could see majority of treated cases of retinal detachment, scarred corneoscleral tear with maybe RD or strabismus which could not be further treated, perforation associated endophthalmitis, thalassus bulba, evisceration, and traumatic optic neuropathy. In healed, in other non-traumatic acquired cases, healed keratitis, mostly the childhood keratitis, diabetic retinopathy, uveitis, end-stage glaucomas, scarred ARMDs, optic neuritis, optic atrophy due to other causes like post-neurosurgical cases, and complicated intraocular surgery were the commonly encountered one. So we try to focus more so on the preventable part rather than congenital part. So we could find that lack of awareness that majority of these diseases could have been treated very early, and because of that the delayed presentation, and if they presented incomplete treatment, just congenital cataract surgery has been done, spectacle taken once and not followed up, was the major reason for amblyopia. Traumatic etiology was more prevalent in our area, and the substandard workplace protective measures was which was actively inquired into during that recording. So we can say that majority of the candidates had not weared any protective measures at work. An additional observation was that the 41% of the candidates were one-eyed candidates who were given 30% of visual impairment certification, so they were lacking the social benefit despite of substandard vision. So we tried to focus mainly on them, what is special in one-eyed patient, and we could see as opposed to congenital versus traumatic, the traumatic cause is almost 2.5 times commoner than the general population which we could find. A similar study was done by Anita et al. In Bihar and published in 2019. They also find the macular pathology as the commonest cause. They had divided the causes in the different age groups, and the most commonly defined causes are the similar one, and the avoidable causes were congenital cataract, complicated cases of congenital cataract surgery and amblyopia missed amblyopia management. A similar study conducted in Kashmir also reveals that unilateral cases are much more commoner, and in and trauma is a significant cause of unilateral blindness. We went through a meta-analysis published in the recognized Lancet journal. The globally recommended causes are same as in the other literatures. However, we differ slightly that trauma cases are more in our study than the global literatures. As we very well know, we had our few limitations for our study. This being hospital-based study, it may not be generalizable to population and retrospective, so exact clinical classification was not possible. So I would like to conclude that the congenital and hereditary are the most common causes of permanent visual impairment. Acquired causes are similar to globally recognized causes. However, in our scenario, ocular trauma was a very significant risk factor of avoidable permanent visual impairment. 42% of visually impaired were lacking social benefits because of current government nomenclatures. So these are my personal recommendations from our study, that there is a very huge need of better awareness in general population that refractive error, squint, congenital diseases like congenital cataract, glaucoma and amblyopia must be treated earliest. A regular eye examination is must in a preschool children, patient with diabetic mellitus, family history of glaucoma, old age patient, and um, everyone knows this, but the mandatory protocol should be followed by the physicians and pediatrician. There is a need of improved workplace protective measures. Pediatric ophthalm and vitreoretinal surgical setups should be available in government or charitable scenario, which may improve the outcome in particular diseases. Government schemes are there to provide the financial support, but a majority of our patients were not knowing that, and that's why they had delayed presentation. There is further need of insight into prevailing government norms for one-eyed patients. Yes, these are recommendations based on one center study, so a large scale study is required. These are my references. I am thankful to my team. Thank you.
Thank you, Dr. Praveen, for this. It's a very good concept, and coming from your area, Bhandara,
Gondia.
Gondia. It's like a tribal area.
area.
So you do not have like whether they have come from tribal group or any
no,
other
ma'am.
group?
That data is not available because some of our patients are like from suburban area, some are for really rural and tribal, and few were like this is a very residential place, so they are working somewhere else. They have come here just for certifications.
So any barriers you could come out with, like if you know what are the barriers,
like
probably
from our recommendation, what we tried to do was like there was a social gathering of school teachers, so we come across already in government setup RBSK is doing their work, but still the primary school teachers are the first one to recognize those, and those are that much literate, so we conveyed to that. And in our institute level, when there are some staff research society committee meeting, we insisted the physicians and pediatricians primarily to refer us these cases, and really the referral had increased. At least to our institute we have tried, and through this forum maybe we will do to better.
Sure. Any questions for him? Okay. So it's good to know that you are working on integration of primary eye care with primary health care. That's fun. And second, what you have done is pretty good. I would suggest to have do a barrier study in your area if you can do that. So that will give you what are the barriers. So you can look into this in future and work on those barriers.
Thank you. Thank you so much, ma'am.
Yeah. Thank you. Round of applause, please. This will be for everyone. We only had. Thank you. So the next speaker is Dr. Pooja Hingorani, and do we have the others? Dr. Pankaj Ranjan, Dr. Prasant Kumar Nanda. So Dr. Pooja Hingorani, she'll be presenting on disability certification, managing a malingrer, a very tough question. Okay, so shall we take then yours? I invite Dr. Anita Mishra to speak on school eye health screening. Please come.
Okay. A very good morning. After a very good banquet, we are now, most of us, in the bed. So thank you, the few who are here. So my topic is affordable corneal blindness and overview. I don't have any financial interest on these things. So WHO study by Lancet and Globe in 2021. Globally, there are 2.2 billion people of vision impairment, and India has become the world's largest number of blind people now. The study from 18.7 million to it has come to 31.6 million by 2020. So by the recent study of 2015 to 2019 in this part, the corneal opacity 7.4% in patients more than 50 years and 37.5% in aged 0 to 49 years. So in most of the cases, the corneal blind are increasing day by day, and mostly they are common in first to second decade of life. As per the survey, the total corneal blindness, the refractive error, cataract, along with it, the total corneal blindness has increased to 8.2%. That is the most significant part of it. So by gender, females are more affected in these cases. The causes, as per the situation, it may be infectious, nutritional, inherited, trauma, iatrogenic. We don't have to go to that theoretical aspect. So mostly in trachoma, xerophthalmia, measles, neonatal ophthalmia, leprosy, and corneal trauma in agriculture work, the corneal blindness increases. So childhood by blindness is little more, which we have to emphasis on that, because 25% is due to cornea. It can have a developmental or educational and future job opportunity, and quality of life is hampered in case of children. So most of the corneal causes, as we have to deal with, infectious. It can be bacterial, viral, fungal, or acanthovial, any infective causes which silently kills the cornea. So here is the most important point which we want to emphasize on this social background, that poverty, illiteracy, and rural areas where they do not have the corneal surgeon to treat, tropical climates, trauma most common in as per the agricultural part, misuse of steroids and eye drops, because that is cheaply available with generic name and all those things. With 10 rupees a drug is available, and most of the time the chemist used to give a steroid drop which gives a very good result. And most important is the traditional methods, either putting the honey or any juice or mother's milk, any other things can cause some problem in the cornea. So poverty, as usual, it is the most common cause. We use these common homemade things, either from honey or milk or any other thing which causes the corneal to do. Trachoma, this is one of the most common causes still prevailing in India. Though we do not see much cases, but it is still there rampant. So treatment of trachoma goes either with surgery or antibiotics or facial cleanliness or environmental changes. This safe method is important. This is the leprosy. Most important is in case of vitamin A deficiency or xerophthalmia. The massive dose implementation is very easy, but fortification and common foodstuffs is vitamin A, immunization, control, and prescribe precipitating infections and dietary improvement to combat that public health problem is effectively needed. Blindness due to vitamin A deficiency, as we have common corneal xerosis, keratomalacia, corneal scarring, all these things are important. Xerophthalmia treatment, when we go for vitamin A deficiency and we do have the doses less than 6 months, 6 to 12 months, more than 12 months, 50,000 units or 1 lakh units, we have to go in the next 2-3 days. Proper treatment, rehydration, and sometimes when you are teaching in case of vitamin A deficiency, most of the patient with malnutrition and diarrhea. So when we treat the diarrhea cases, most of the general physician, they forget about the eye condition. That is the most important part one should remember, because while treating the general conditions, if you just put a drop into the eye, that will save the eye, and the general condition improves of the patient and the eye goes back. So children with blinding xerophthalmia are often severely ill. Proper treatment will save their sight. So most important then comes through us is trauma. We are very happy to enjoy the Diwali is coming, and once Diwali comes, again we do suffer from these corneal causes. It can workplace injury are very common in these patients. Chemical injury, we don't have to signify on the certification. So prevention, eye safety at work, copious irrigation, because there had been a alkaline injury due to a balloon blast in case of Bhubaneswar while I was a house surgeon at that time, nearly 30 years back. That cost till us almost 100 crores, because these 15 people are roaming from all over India, from this hospital to that hospital, just because it has not been irrigated. There is no, it was in a flag hosting day, no water was available, and whenever they reached the SCB Medical College Cuttack, it was already 6 to 8 hours, and in between nobody has irrigated the things. 1 minute, ma'am. So corneal dystrophy as usual is very common. I don't have to go to contact lens users are most common causes of this. So either you can. So NPCB guidelines strengthening the advocacy, reduction of the disease burden and human resources. So general strategy, identification and infants, preschool children, these are the essential supply of drugs. To eliminate the corneal blindness, multi-program studies needs to be developed. Control preventable causes requires extensive public contact. Curable and treatable blindness requires a spectrum of care. So our vision is social impact, affordability, quality and accessibility. So just take home messages. Corneal blindness ends with mostly corneal opacity. So solution of corneal transplantation is there. So better take care of the corneal transplantation program, eye banking program, but prevention is better than cure. So all the when what's a corneal opacity comes, eye donation plays an important role. So thank you very much for patient hearing. Thank you, ma'am.
Thank you very much.
Yeah.
Sir, you have covered everything about
Oh yeah.
cornea in 7 minutes, I would say, because it
Thank you, madam. Madam, it is now time for you. Thank you. Thank you.
any questions?
Yeah, anything you can
Any
ask.
questions for sir?
No. Thank you. I think they have understood totally or they have not understood anything. Either the two
No,
conditions.
you were
Thank you.
very clear. Thank you so much.
Thank you.
I would once again check if Dr. Pankaj Ranjani is here. Dr. Pankaj Ranjan, Dr. Sabyasachi Patnaik, Dr. Pooja Himwara.
Good morning, everyone, and thank you for having me here. As I don't know how many of you all are running a disability board at your places, but if you are, then you know that this is a common problem. And especially so when you become from a disability board to one of the verification centers for NEET exam. So as we all know that there are a certain percentage of seats kept aside for PWD quota, which is persons with disabilities, persons with benchmark disabilities. It's PWBD as it is called. And there are 16 centers in India wherein this has to be verified. So what happens is the child who is going to appear for NEET, the eligible candidates, they'll first go to a government hospital, a disability board, and get their UDID certificate, which makes them eligible to appear in the NEET under the PWD quota. But once the results are declared, they must come to one of the 16 verified centers and recheck their percentage of disability. And if it is shown to be 40% or more, they can be classified or they can be considered as under the PWD quota, provided that with the use of low vision aids, that 40 to 80% disability is brought to under 40%. So the criteria is for PWD 40 to 80% for visual disability, and after that you get it down below 40, anything below 40 to be eligible to pursue MBBS. So that was the principle. And what we wanted to know is, this is the definition of PWD, and benchmark disability is 40 to 80%. As I said, 40% is the cutoff, the benchmark. This is the chart that is followed for the UDID. You all must be all following this. For the percentage disability, you can follow both the visual acuity as well as the fields. So visual fields is also one of the criteria. So what we did, we were seeing a lot of students who came as UDID 40% and above in benchmark, and we saw that many of them didn't verify in our center. So there was a huge gap between the UDID, the percentage brought by the students for UDID, which is 40% and above, and the ones we gave them finally, the percentage we gave them, and many of them didn't turn to be eligible. So we wanted to know the difference between the primary center and our center, which is a tertiary center, and the ratio of students who were wanting to be eligible, so those who applied as to who actually became eligible. So that is what we wanted to see, and in the light of malingering, and what are the causes and how to catch it at the primary center level itself. So it was a retrospective study. We took it from our records from the past 4 years since we've been the verification center. We had complete data for 154 students, and it was consecutive sampling. So all students who were eligible for NEET and who had their result in their hand and who had got their 40% UDID certificate. Those who were excluded were those who didn't have a certificate or a result in their hand. We had it in the Department of Ophthalmology, and the data was collected. So they presented to the Opthal department, the data was retrieved and categorized. Can you believe it? What are the stakes? The stakes are that the average rank of these students was around 5 lakhs. Anything from 11 lakhs to around 1 lakh we found. The All India AIR rank was, the average was 5 lakhs, and the average it came down to after applying PWD was 1300. Now do you know why I'm presenting this? So the stakes are very high. So if we had gone according to what the UDID they got, everyone would have got eligible. So except for 3 who were under 40%, all remaining were eligible according to the existing UDID certificate for PWD quota, but actually only 44 or 27% were eligible. Only 27% of everyone who came. So amongst the UDID, only 3 patients, students had 40%, less than 40%. Everyone had either 40 or more than 40%, the blue bars. And in our case, just see, it's a reversal. The oranges were what we verified. 110 out of 154 students were not crossing the benchmark, So this is, if you see that in the agreement, let's say how many times did we agree with the primary center? So in the less than 40, there were just 3 students. So we agreed 66% of the times, and only 1 was eligible. Actually, they underestimated the eligibility. So one of them, who was 30, actually turned out to be 40. And amongst those, it'll take some time, ma'am, a little more time if it's okay. So amongst those above 40%, we agreed with only 3, and for 25 students, it was less than what was given, and for just 1, it was more. So these were the number who were eligible and not eligible. For those equal to 40, a huge percent, which is, you can see 91 out of 122 turned out to be less than what they came as. So most of them were ineligible. So if you see it percentage wise, I'll show you that amongst the 122 students who came as equal to 40%, 91 were less. You know what? Out of those 91, 27 were one-eyed. So there's a very high chance that the 30% is made 40%. Very high chance. 30% is made 40%. So 44% of them were just given a 10% higher weightage. And in the above 40% also, we didn't agree with a huge percentage, which is 25 out of 29. And even amongst these, the highest was in the 30% category. So the 30% were the ones where they were given a higher percent. So this was a summary that amongst the 154 students, we agreed only in 27% of the diagnosis, and in 11 we actually gave higher scores, but in 75% the percentage was less than that given in primary. You know how much less? The average, it was 23% less. 23% less. You know what was shocking? What surprised us was that 30% of those who came for PWD quota had 0% disability. 0%. And amongst the others, 84% of the students had exaggerated scores, out of which 30% was 0% disability, so they were like fully exaggerated from 0 to 40, and the others were somewhat exaggerated, like some were one-eyed. Like I said, 30% were one-eyed, and the others were somewhere in between, like they had 10% or 20%, and they were given as 40 or more. So why is this happening in a primary center? Maybe the lack of index of suspicion, that this has to be suspicious, or lack of sophisticated equipment to rule out malingering, non-availability of visual fields, because that's also a criteria, inadequate training of the local doctors there, confusion with the criteria, because some parts of the criteria are not very well defined, and can it be, sympathetic with the student ki chalo 30 ka 40 de dete hain, kya hai, zindagi ban jayegi. So, and why is this trend happening? Because you saw how huge a rank difference there can be, the difference in asking percentage, the Indian stress of bacha doctor ya engineer ban jayega. And so what we can do and what we did, how did we get this percentage finally? So first of all, we took the parents out of the room. We took the guards inside. Because there were a lot of fights and people were threatening us and things like that. And then what we did was repeat vision following counseling. Students ko bitha ke counseling. Then randomization on the Snellens, logmar charts where they could not guess that this could be 6 by 24 or this could be 6 by 18. and words 4.test, and of course, next stage was visual fields, and we also resorted to VEP. One thing that we have to warn ourselves against is amblyopia, because amblyopia, there was a 28% incidence amongst primary centers, and for us it was only 16%. We're very clear about the definition of amblyopia. So in conclusion, 30% of all students had no disability at all. 25% of the total were one-eyed and were actually not eligible for the benchmark disability. 95% amongst these had an exaggerated score and were eligible as per the primary center. Now, among 70%, this is amongst the 70% with disability, they had an exaggerated score. Now, 84 of the total had exaggerated scores, and only 28% or 29% were actually eligible for the PWD quota. So what we can bring it down to is awareness, education of the primary care ophthalmologist, fine-tuning of the criteria, beware of the diagnosis of amblyopia, high index of suspicion, use of certain modalities, and parents outside, guard inside. Thank you.
Thank you very much. I mean, this is something new for me, but we'll take the questions in the end if there are any. Thank you. Now I invite Dr. Anita Mishra to speak on school eye health screening to catch them early, which probably would help Dr. Praveen in doing that in future.
Thank you, Dr. Rathi. So, school eye health screening, why should we catch them early? Now, why school children? Because in India, uncorrected refractive error is the second most common cause of visual impairment after cataract. Almost 5% of school children have refractive errors with BCVA of less than 6/18 in the better eye. Prevalence of myopia is almost 7% in the school age group in urban area, and it has been exaggerated into epidemic proportions because of the use of mobile phones after COVID era. Refractive error is till now the most common cause of reason of visit into an eye OPD. Now, going to the history, what were the problems in school eye screening in the previous models? If we see the gap analysis tool, there was no analysis of the failure of previous programs. So, our state, Odisha, on World Sight Day 5 years back, we launched a program named Sunetra, or Healthy Eyes, by the government, which is spread over 5 years with the bold message as eye care for all by 2022. Now, what we analyzed about the failure of the previous programs were that there was no gap analysis. And even if there was a failure to address them. There was inadequate manpower, unequal distribution of trained people in rural and remote areas, and there was poor quality of care, and there was no standardization. So the first protocol was a proper planning of the Sunetra program. Now on the right side we can see that this is the planning of the ongoing 4 months. Now each plan is of a duration of 3 to 4 months, and at the end of the plan and the end of the implementation we again do a gap analysis. Next is identification of human resources in that catchment area. That is all the ASHA NM workers, the teachers, then ophthalmic assistant and government officials. After that, the teachers undergo training and they issue a yellow card to the students who have been screened. If they are referred to an ophthalmic assistant or eye specialist, it is with the help of a blue card. Then we conduct the screening, that is mostly with the help of the teachers. The preliminary screening in the school, the examination is then done by the ophthalmic assistant, and then the spectacles are provided by the optician, and they are dispensed again by the school teachers. Now the arrangement for refraction of those who have lower visual acuity is by a qualified ophthalmic assistant with proper provision in a dark room and trial set. He then sends the prescriptions to the optician, and there are two types of arrangement for provision of spectacles. Either free spectacles are taken from the optician, or there is direct payment of the amount to the guardian, and then they can do spectacles on their own. Most important step is monitoring the progress after every 3 months. That is evaluation of the screening program with these 9 questions, which can identify any gap in the program and which can be subsequently analyzed. Now on the right side is the form of the monitoring list, and below it is the district wise distribution, which report is sent after each 3 months to the government officials as well as the district headquarter program officer. Now what were the gaps in the previous programs? On the left side you can see that the vision was just seen with a torchlight in a very haphazard manner by the teachers which were not trained. Now on the right side are the gaps which we have taken care of. That is, now there is a stringent record keeping. Then there is a parents teacher association or interaction every monthly, so that the parents can give the symptoms of the children, and we can know which children are at risk, so that they can be evaluated better. Then there is insistence of glasses of children who are already wearing glasses. The teachers insist that they wear glasses regularly. And most important is, after the dispensing of the glasses, there is a 1-year follow-up, and the record is being kept to know the causes of non-compliance of the children who are not wearing glasses. Now another gap in the left side, how the vision was being taken previously in a dingy room, and there is no standardization of the chart. Now on the right side we can see that now we have a standardized E-chart. This vision screening chart is white in color with only 5 black E optotypes equivalent to 6/12 of the Snellen's chart. This is provided to all the teachers in the school who are trained, and they just need to identify children with poor sight. They need not take the vision of all the children. They just need to cut off or benchmark the children having less than 6/12 vision and send them with a blue card to the optometrist. Now this is again the flow chart for the teacher. If the eyesight is not good, that is less than 6/12, send him to the optometrist. He sees for any refractive error and dispenses glasses with the help of the optician. If any other complication in the eye, myopia of more than 4, then he is sent to the nearest vision center or the ophthalmologist. Now apart from vision screening, there are integration of eye health screening like pamphlets for healthy eyes and how to prevent injuries for teachers and children. Now these are the training for teachers to identify these common problems, and they are provided a kit with tetracycline ointment, eye pads and all to know which diseases they can treat at the school. I'll take just one more minute, ma'am.
Yeah.
Now these are the diseases which the teachers will refer. Now during Holi and Diwali, there is a parents-teacher interaction for special precautions, and especially children after class 8th, before they do their chemistry and physics labs, they are also given a special talk of preventive measures of injury. Now apart from that, the teachers are provided free spectacles for presbyopia and free assessment of their glaucoma and diabetes, so that their eyes remain healthy. Now, the Sunetra program is not a standalone vertical program dealing only with refractive error. There is integration with the Ministry of Health and Ministry of Education and the midday meal program. And most importantly, there is eye care for all, that is inclusive education in integrated schools for children with low vision. And under the Sarva Shiksha Abhiyan, they provided free low vision devices by the government so that they can study in the normal schools in an integrated manner with their peers. So why school children? Because it is the age of rapid physical mental development. They are exposed to injuries which can be avoided. They need to benefit maximum from the education program. And if we inculcate healthy habits, we are inculcating healthy eye habits in the future adult. We are guarding the school health and ensuring healthy adults for tomorrow. So we are undertaking this Sunetra program so that all may perceive and not merely see. Thank you.
Thank you, Dr. Mishra. What you said is very true, that we have to catch them young so that the disability dallies would reduce for them and the quality of life, that is college, will increase for these.
Yes, ma'am,
And both of you, Dr. Nanda and Dr. Mishra, has brought out a very good point, that is now Diwali is coming and both of you have said that we need to work on that. Probably through AIOS we can have certain things which can be projected on TVs or WhatsApp messages or whatever way on digital media. We can prevent injuries for the kids. Any questions? We still have time because we have covered all the lectures. We have time for questions. Yes, there is one.
Ma'am, you have primarily focused on vision screening in school children. Do the direct portable auto reps have their importance in directly screening?
No, what we are...
No, yours method was this one.
Yeah.
Have you any experience with this method, that few centers
portable auto ref, I don't think that will be cost effective because you can't... Yeah.
Because for pediatric patients you have to do
cycloplegic? Yes.
so you cannot say that you would be doing.
So that cannot be practically used
Yes.
as a tool. Yes. Thank you.
I just wanted to ask a question to Pooja ma'am, that I am also in this medical board and we are evaluating low vision patients
Yes.
for this NEET entrance.
Yes.
Ma'am, suppose there is a retinitis pigmentosa case or any case which is likely to worsen. So how do you certificate? You give a 40% permanent or 40% temporary? Because there is no specific guideline what temporary and permanent mean, whether it is likely to worsen.
Yeah.
So will...
So
yeah.
there is, ma'am, there is this the original GFR of the government, which everyone follows for the UDID.
Yes, ma'am.
We give the percentage based on that, the one I showed. And the second is the MCI, which only we are following, the 16 centers for the NEET. So what happens is that when these students are likely to progress, and they're 30% today,
Yes.
this even is true for things, conditions which may become better after surgery, like keratoconus. So right now the child is waiting for a cornea. It's a scarred cornea, but he is 30%. So we give 30% and likely to change or valid for 1 year. We put that in,
No,
because
where
that
do you
is
write,
so
do you write it
anything
temporary or
that's
permanent? That is,
so yeah.
we are
So the
confused for that.
disease has to be permanent, but the percentage may be temporary. So the certificate can be temporary. So this is in the fine reading. If you see those documents, the disease has to be a permanent disease. It should not be reversible or this thing. And some treatable diseases like keratoconus, which may undergo a keratoplasty, PK, you cannot consider it as a regular treatment. But for cataract, you can't give disability to all
No,
cataracts.
that is not
So that is
considered
true.
also.
So the thing is that the disability should be permanent, but the percentage and certificate can be temporary.
No, can I interpret? There are clear-cut guidelines on this. You have to write temporary or permanent, where you can write temporary and permanent.
No, sir,
Only
there are
2-3
no
points are
guidelines.
there. You have not gone through the book.
Yes, sir. I'm not.
You have not gone through the book. The guidelines of office, there is a clear-cut guidelines where you can mention temporary or permanent.
No.
And second part is, when madam says that why the controversy is there, lot of patients has come from 30% or 0%, now they are going for 40 or less than that, or whatever the things may be. That is because the certificate when originally is created by a young doctor in the periphery. He has lot of pressure. Lot
So
of pressure
that's
from
one
the
of
local
points I
touts.
mentioned, the training and
Yeah,
the-
local
yeah.
touts are there, local sarpanchs are there, local politicians are there, and sometimes money matters also. So many things which gives them, why should I bother? Give him, if it is 0 or 10, give him 40.
40.
When he will go
That's
to the
happening.
medical board
And
by the
that's-
college, at that time he will be
So
screened.
that's the reason
So
the
that's the
16
reason
centers have to
for
be
that
really
reason,
even more
madam,
strict. Yeah, yeah.
we have written to the government of India for the 2-3 things.
Yes, yes.
So with that, they have got a warning also. Once we have written to the railway board also, and from the railway board, it has been concerned to the concerned doctors that they should not write all these things. After this thing, there is certain percentage has decreased in the working atmosphere. Moreover, there is a visual handicap ministry in the every state government. That is a public health industry. With that visual handicapped department, they also give a warning to these doctors who give a false certificate. And the regular notion is that regarding the one-eyed controversy is there. Every person has a little controversy. If I am blind by one eye, please give me 50%. So that
These are
is
the
a
fights that
general.
the children always
so
put up with
something
us,
has to be
yes.
changed in the modules also.
Yeah.
We are still there with 30%. And if it is 6 by 24, 6 by 24, it jumps to 60%.
Immediately, yeah.
Immediately from
no, 40, 40. It jumps to 40.
60%, madam.
No, 624 in both eyes, sir said, yeah.
Just one
Ah,
line
so
change.
it goes to one line
very true.
changes, it goes to 60% in the new
So-
new line.
True,
In the new,
New
pro
person,
forma
yeah.
by the
618
MPCB
and
guideline.
624.
GFR.
So it has been again, I'm in that board also. So we have also controversy that may change by the AIMS people very soon or in a recent past. Within a 1 year or 2 year, the government will change that guideline to again make a controversy of 30 to 40%. But malingering and these things will continue.
Continue.
So only this will
There have to be ways
this
to
is this will continue.
high index
And
of suspicion.
even if in a medical college also, they catch hold of the young doctors, the certificate will be given by the HOD, but examination is done by the assistant professor and all those things. And there are so many touts, both from the superintendent, principal, ministers, local touts. Some pressure is there everywhere to make it, please ma'am, what is there? The patient will get a seat for the medical college or engineering college. So, but only thing you have to ask your conscience that you are giving a genuine,
True.
you are not giving a genuine fellow means you are depriving a genuine handicapped person.
True.
If you consent to that, then
Yes.
only it can be done.
Yes.
Again,
And-
this temporary and permanent, there is a clear-cut guidelines.
So in
in the
which,
visual handicapped board.
which state is this? Because it's
Odisha,
not
ma'am.
very-
There is
Odisha?
no guideline
in
actually,
Odisha,
sir.
sir, actually in those 2 pages, which we read and reread and reread
No,
50,
there
80,
is
200
not.
times.
There's no
And then
guideline.
we've gone to the American guidelines and then seen that even the angle definition for the
Yes,
visual
10
field
degree or
is
20
actually
degree.
subtended at the center,
Yeah.
not from the center. So it's actually a diameter, not a radius.
is actually
so
the diameter.
Yeah, so there were very fine things which are not clearly mentioned in the protocol.
And we
Ma-
land
So
up
we
with
madam, it
need
legal
is a-
to
problems
give
because of that.
recommendations. Yeah. And so another thing that I always tell the students when they fight about this, about the fact that one eye is missing, it's 50% out of 2 eyes. So then we are supposed to tell the patients this is how it works, is that we tell them how much percentage of your life can you, how much percentage of your work can you do? Because disability is a functional disability. How many functions are you able to perform yourself, by yourself in your life? With a lack of one eye, you can perform actually 80 to 90, but the government is giving you 30%. So actually government is giving you 70% ability or 30% disability, whereas you can actually perform 90% of all your actions in your life. So that is when they keep quiet. This is the way the government thinks. It's not like one out of the 2 eyes is. So this is how we have to explain, and
So we
are
have to
doing
tell
it,
them
sir,
that
yeah.
we are sympathizing with you, but as per the government guidelines, as we are government servants, we cannot go beyond our limitations.
True,
We
true,
have got
true.
our limitation, but we are sympathizing with you. That is the only thing, and then rest one take care.
Yeah, but it was.
Thank you, ma'am.
It was indeed an eye-opener for every one of us. Like, this is how it is happening. Thank you
Yeah,
for
but
that.
still we are in the controversy. Like if you give 40% and permanent, then only they're going to get the benefit. But we have faced legal challenges that we have given 40% permanent for some corneal opacity.
When
But
legal
after they have
challenges are
undergone-
coming,
Yes,
legal
sir.
challenges are coming.
Huh.
Now the government has told once the medical board gives a report, you cannot challenge in ordinarily or go to the
They come for the
superintendent, give
review,
a
sir.
comeback review. You
Yes.
cannot do a review. It is to be reviewed only after
By
the
the
order of the
appellate
High Court.
board.
Yes.
Yeah.
So
Ma'am, we have
after
faced
our
such
review
cases.
is straight away High Court, and then one
Okay.
of the other 16 has to see it.
Yeah.
So
Yes.
that is how it is.
Ma'am,
So
some
we'll take the last comment
ma'am,
from him.
just one thing.
And then we are close because
okay, ma'am.
it's like 10.
Thank you, ma'am.
Thank you so much.
Thank you so
Thank
much.
you all the speakers. Can we have a photograph?
Yeah, yeah.
With